This synchronous session will review whatever we talked about or I talked about in my 3 videos. Unfortunately, I received just a very small number of questions to be discussed. I'll just go over them and then open the floor for the discussion and maybe ask you some questions. So let me share my screen. Okay, guys, can you see this Word file?
Yeah, we can see that.
Okay. Okay, the very first question was yesterday. I took a look at it today, which says this was on the YouTube under the video. Why does the tremor occur only at rest? And the second question, how does arteriosclerosis cause Parkinson's disease? Okay, so these are kind of pathology directed questions, not pharmacology. However, I'll just try to elaborate quickly on them. Regarding the resting tremors, I just brought these things because it's quite complicated. The issue is quite complicated. It's out of the scope of this lecture, but it is one of the most noticeable features of Parkinson's disease. Okay, they are caused by complex interaction between number of factors, including substantia nigra, basal ganglia. Substantia nigra is part of the basal ganglia and the thalamus, okay, as well as change in the level and action of dopamine, okay. So they classified the Parkinson tremor into, or the Parkinson disease itself into tremor dominant and non-tremor dominant, these subtypes. Actually, when the Parkinson patient is tremor dominant, means that the patient experienced so much tremors. Non-tremor dominant means that there is no much tremor, and they found out that the tremors with the Parkinson disease predict like a good prognosis for the patient, because this means that there is still some remaining neurons in the basal ganglia. So the relationship between them and the dopamine is unclear. Sometimes they respond to dopaminergic medications such as bromocriptine, levodopa, and others, and some do not. So that's why I said it's complicated. We don't know exactly the reason of that, but they usually are associated with increase in the cerebellothalamic or thalamocortical circuit. Okay, this is a very important point here, that the tremor is triggered by the basal ganglia. Yesterday, when I posted the video, I said the dopamine triggers or initiates the movement. Okay, initiates the movement. Then we will depend on the balance between the cholinergic and dopaminergic activities, right? Can you hear me?
Yes, doctor, we are following.
Oh, okay. So if now in the patient with Parkinsonism there is still remaining basal ganglion neurons, so they will still they can initiate movement. And here the cerebellothalamicortical circuit are actually associated for what's called action tremor. Yeah, this adds another layer of complication, because there are so many tremors, at least 5 types of Parkinson tremors. One of them is the resting tremor, which occurs only when at rest. But if you hold something or you catch something, if you shake hand with someone, the tremors go away. So the second type is action tremor, which occurs when you do something. So it's almost opposite to the resting tremor. So the cerebello-thalamo-cortical circuit is responsible mainly for the action tremor. So you initiate and then stop. But again, the dopamine level is not enough to still control. As I said again, let me repeat again. I start with dopamine that initiates the movement, okay? So now the movement starts. Then the dopamine level itself is less as compared to the cholinergic activity. So now the cerebello-thalamo-cortical circuit will continue with action, kind of action tremor, so that they will stimulate the tremor. So there will be kind of a spontaneous tremor because they're going just going. So there will be such a tremor. This is just my humble explanation of that, but again, the issue is quite complicated. Let me recap. So now the tremor is initiated by the basal ganglia, by the dopamine. Then the cerebello-thalamo-cortical circuit will continue giving this shakiness and these tremors, okay, continuously, or as long as the patient does not hold something or anything. Does that make sense?
Yeah.
Okay, the second question was how does atherosclerosis cause Parkinson's disease? Actually, this is called vascular Parkinson, okay, or atherosclerotic Parkinson, okay. It accounts for about 4 to 12%, and there will be multiple lesions in the basal ganglia, okay. So now there is atherosclerosis. The blood supply to the basal ganglia is minimized or not enough. There will be some death in the basal ganglion neurons. There will be less production of dopamine. That's why they call it atherosclerotic pseudo-Parkinsonism, okay? Because they found out that they don't have the pathological hallmark of Lewy bodies and other stuff, alpha-synuclein and other stuff in the pathology or histopathology. So they call it pseudo-Parkinsonism or atherosclerotic pseudo-Parkinsonism. Okay? Are you okay with that?
Yes, doctor. Thank you.
You're welcome. Okay. I think the same student, maybe Auni, I think, asked what happened in advanced Parkinsonism that renders MAO-B inhibitors, silidylene inhibitors ineffective. Okay. Let us agree first that we are using MAO-B monoamine oxidase B inhibitors, okay, such as silidylene, lasagilene, okay, to prevent breakdown of levodopa and dopamine, okay, in the CNS, because MAO-B is more in the central nervous system, okay? You agree with that? Guys, come on, show me you are awake.
Yeah.
Yes, doctor. Yes.
Okay, so the question is, does this class of drugs work by themselves? So if I give just MAO inhibitors, they will treat or manage the symptoms of Parkinson, or they depend on something else?
They need
Depend
a
on
source of
dopamine.
dopamine, doctor.
Sorry?
They need dopamine.
Yes. So what happened in advanced Parkinsonism? What do you expect, at least?
There's decreased level of dopamine.
Yes, there will be a significant degeneration of the basal ganglia, right? So there will be a significant decrease or marked decrease of the amount of dopamine, right?
Yeah.
So now they are not going to be helpful because okay, they will predict the amount of dopamine, which is already less, already is not enough. So in this case, you might need to use the dopamine receptor agonists. Dopamine receptor agonists such as cabergoline, bromocriptine, and others. Okay, pramipixole and others. Okay, so that makes sense now. I think we went with it sequentially and stepwise. So are you happy with that?
That makes sense.
So again, in advanced Parkinsonism, there will be a significant degeneration of the basal ganglia, and the production of dopamine is quite low, extremely low. So now the MAO-B inhibitors, please remember that MAO-B inhibitors, they have their own side effect profile. So if you compare the risk-benefit ratio, so now we are giving the patient so much side effects, okay, many side effects, along with minimal benefit of saving the remaining dopamine, which is already less. So you might not use these. You might switch to other medications such as dopamine receptor agonists. Okay, are you okay with that, guys?
Yeah,
Sounds
doctor.
good.
Yes, doctor. Understood.
Okay, so we are done with that. So, okay, there's another question came just right before the lecture. The student said that there are points that he or she circled, he or she does not understand. Advantages. I think I brought this slide today. Yes. So advantages of dopamine receptor agonists. Okay. But let's go over the whole thing. They don't require enzymatic conversion to an active metabolite. This refers to what? Which one needs conversion into active metabolite?
Levodopa.
Levodopa, right? So these guys are not like levodopa. They go by themselves and they activate the receptor right away. Okay, this is one advantage. The second advantage, they don't depend on the functional capacities of the nigrostriatal neurons, which means that now if you give levodopa and the functional capacity of the substantia nigra is quite degenerated, was quite low. So now I have the precursor in my hand, okay, but the machine is sluggish, it's not working that much, right? So levodopa is not going to help, right?
Yeah.
So again, maybe it's not clear. So now I'm comparing here, this part compares levodopa with dopamine receptor agonists, okay? Dopamine receptor agonists, okay, they are, suppose the receptor is here, okay? And I need, or suppose the receptor is here, okay? Down here, look down, okay? And I need to touch this receptor, okay? I need to touch and activate this receptor, okay? This is the final destination. The last thing I need to do is to activate the receptor, right? But before that, there are other steps that levodopa need to be first converted to dopamine, and dopamine can activate the receptor, right?
Yes. Yeah.
Okay. So what about if the levodopa is there? Yes, I'm giving levodopa. I'm using carbidopa and benzodiazide and all of these things to protect or prevent the waste of levodopa in the periphery, and so much levodopa is migrating through the blood-brain barrier, and everything is have so much levodopa. But the machine in the middle here, the machine here is not functioning well. So there will be less dopamine that can activate the receptor. That clear?
Yes,
Okay. Yeah.
yes, clear.
Yes, doctor. Clear.
Okay. So this is again another comparison with levodopa. if this is clear, let's move to the next bullet. They don't compete with other substances for active transport into the blood and across the blood-brain barrier. This refers to whom? Refers to which drug?
Levodopa as well.
Yes, levodopa. Okay.
Yeah.
Levodopa competes with other. We say don't eat high protein diet when you take these medications because protein itself contains amino acids. One of them could be 99% it would have tyrosine, and tyrosine compete with levodopa for their passage through the villi into the blood, and also when you go through the blood-brain barrier, it will compete with tyrosine to pass through the L-amino acid transporter through the blood-brain barrier. Okay, so these drugs, dopamine receptor agonists, they don't need that. Okay, they take it from the end. Okay, they go just right to the receptor down here. If you consider this is the receptor, even though this receptor says stop sharing. So, but just I found any visual clue. So the dopamine receptor agonist will just activate the receptor right away. So this is the advantage of these drugs as compared to levodopa, which depend on other factors, including L-amino acid transporter and the functional capacity of the neurodegenerative neurons and others. They selectively affect certain dopamine receptors. We need D2 mainly, maybe D3 also. I think that's the, I think this is what he circled, he or she circled.
So, doctor, just to confirm, do you mean the machine by the blood-brain barrier, or when
Thank you.
you mention about
Thank you. Number one, I really appreciate your question. Okay, I'm happy that the student, when the student does not, conceive something, they ask. I appreciate that. Who's talking? Can you speak?
me, doctor?
Yeah, another Ain. Okay, or Ain. Your question is, can you say the question again?
So I just wanted to confirm regarding the nigrostriatal neurons. You mentioned about the machine. Is the machine the blood-brain barrier, or
No, the blood-brain barrier is the gate. Okay, blood-brain barrier is the gate through which the levodopa will pass. So now you are importing something, you use Shopee or Lazada, but it's importing something from China. So this levodopa you're importing from China will pass through the customs, right? Then it will come to deliver to your house. You have a machine in your house which is the nigrostriatal or substantia nigra that can convert levodopa into dopamine. So this is the machine I mean. That's clear, Ain?
so they assist in the conversion? I got it. Thank you, doctor.
Yeah, you're welcome. So the passage is different from the machine itself. So just suppose, I know this is not a clinical situation. Suppose you inject levodopa into the brain. Okay, the things will be the same, right? I still need the substantia nigra in the basal ganglia to convert this levodopa into dopamine, right?
Yes, doctor.
Okay.
So regardless the way of access to the CNS, levodopa needs this machinery or machine, which is the substantia nigra, to convert levodopa into dopamine. But here it's not functional. It's not. It's already the advanced Parkinsonism. There will be a big number. I mean, huge degeneration, because if you remember in the first video, sorry, I said there is no when you talk about Parkinson's disease treatment, it's kind of not an accurate word. Actually, it should be management of symptoms of Parkinsonism or symptomatic management of Parkinsonism. Because number one, you cannot treat the disease. It's number one. Number two, you cannot even stop the progression of the disease. You just can delay the progression of the disease. But the disease is going on. You are using levodopa, whatever, okay, but the disease is still going on. So there will be, in advanced Parkinsonism, there will be quite degeneration of the nigrostriatal neurons. And the machine itself is not working. Okay?
Understood, doctor. Thank you.
You're welcome. Okay. I think this is the only questions I received through the, oh yeah. I think this is what the student circled here depends on remaining
Yes,
dopamine.
that was me, doctor. But basically, I think I understand it now. It's because, like the dopamine receptor agonists, it doesn't have to be converted into anything to work. But like unlike levodopa, that one has to be converted into dopamine, which is dependent on the nigrostriatal neurons. Is it?
Perfect.
So that's why.
Perfect.
Right. Okay. Understood. Thank you.
Yeah, good. Welcome. Okay, I think. Okay, this is yeah. I think we already covered that part. Unfortunately, these are the only questions I received. Do you have any other questions?
Doctor. Okay. Hassan.
Go ahead. It's fine.
Okay. I'll ask first. Doctor. Regarding levodopa and also dopamine receptor agonist, does it mean that dopamine receptor agonist is more superior compared to levodopa in clinical use?
Very good question, Irshad. Actually, if you look at the prototype or the drug of choice for treatment of Parkinsonism, you'll find it's levodopa, right?
Yeah.
Okay, this is what you are trying to refer to. There is an advantage of there are advantages of dopamine receptor agonists. We already mentioned them here, okay? But if you talk about dopamine receptor agonists, they are like what they call it, you know, like substitute teacher. Okay, so the teacher is not there. So suppose it's the math teacher, the English teacher will just go there, or maybe a teacher with much less expertise will just take over until the main teacher comes back. Okay, so if you talk about the ligand receptor binding, okay, which one you expect that binds better, generally speaking? The natural agonist, which is dopamine or pramipixole or bromocriptine or others. Which one you expect that will result in a precise fit on the receptor?
The natural one.
The natural one, right?
Yes, the natural one.
The natural one. So this is the advantage of the natural one. That's why we use levodopa along with carbidopa or other peripheral decarboxylase inhibitors, because levodopa is valuable because it will kind of bring the situation to a I wouldn't say normal, like, but just little normal situation by providing the dopamine itself, and this dopamine is coming from the substantia nigra. Okay,
Okay.
that's
Clear.
why we use these drugs. They could be used along with levodopa to decrease the dose of levodopa. They could be used later in advanced disease if there is no so much substantia nigra neurons remaining and others. But they have, you know, as any class of drugs, they have their pros and cons, advantages and disadvantages. Okay?
Okay, doctor. Thank you.
Okay, welcome. I think Hassana was trying to say something.
Yeah, I just wanted to clarify something. Just out of curiosity, I was wondering why does the monoamine oxidase inhibitors, the MAO inhibitors, how do they lead to hypertensive crisis? Is it because you have accumulated levels of norepinephrine, epinephrine? Is it because of that, or yeah?
Yes, perfect. Yes, yes, good. Please remember that. Good question. So the question of Hassana is from where comes this hypertensive crisis induced by MAO-B inhibitors when they are used along with levodopa. Number one, remember that levodopa itself is a precursor not only for dopamine but also for other catecholamines including epinephrine and norepinephrine. Okay, Hasana and other. Okay, guys.
Yes, doctor.
Yes, doctor.
Okay, so it's precursor for all of these catecholamines. All of these catecholamines can raise the blood pressure. Norepinephrine number one, of course, okay, followed by epinephrine and then dopamine. So if you use MAO-B inhibitors, okay, yeah, the second component is that MAO-B inhibitors are not like psilocybin as not absolutely selective for MAO-B. Remember, right? Guys,
Yes.
yeah. So at small dose or normal dose, they can inhibit MAO-B, but to increase the dose little bit, they can affect also the MAO-A. MAO-A, where is MAO-A?
The intestine and the lungs.
Yeah, in the periphery, right? So this will if you use this guy, okay, MAO. If these guys inhibit MAO-A, now there is a big chance that levodopa is going to be converted into dopamine, and dopamine can continue to epinephrine, norepinephrine, and these epinephrine and norepinephrine are not going to be degraded by MAO, okay? So there will be so much of these catecholamines which can cause severe increase in blood pressure. Okay? Is that clear, Hassana?
Yes. Yeah.
So let me recap. We have two components, okay? Component number one is the levodopa itself is a precursor of other catecholamines, of dopamine. I cannot say other catecholamines. Levodopa itself is not considered catecholamine, but dopamine, epinephrine, norepinephrine are catecholamines because they have this catechol nucleus, this benzene ring with anyway, the chemistry, you know, with the two hydroxyl groups and the amino group. So these catechol agents like dopamine, norepinephrine, epinephrine, levodopa can be converted into these guys in the periphery. In the presence of MAO-A inhibition, there will be enhanced activation, or exactly not activation, decrease the breakdown of these catecholamine, which means that their level is going to be high and they can increase blood pressure severely. The second component, I said that MAO inhibitors, we selectively need MAO-B inhibitors because MAO-B is more predominant in the CNS we need to keep dopamine up there. Okay, I need to prevent degradation of levodopa and dopamine up in the central nervous system, specifically in the substantia nigra. But they are not so much selective. They can also affect MAO-A. If you affect MAO-A or inhibit MAO-A, there is a significant chance of increase in the amount of catecholamines, dopamine, epinephrine, norepinephrine, which will be associated with severe increase in blood pressure, which is called the hypertensive crisis. Is that clear?
Yes. Yeah. But doctor, just out of curiosity again, like,
if I
okay,
know, I mean, I will do my best. Okay, to get more curious. I don't know how curious you are going to go. But anyway, we have the tutorial 2 days from now. We can review everything. Go ahead.
No, because like certain drugs, like let's say if the receptors become repeatedly inactivated, they become desensitized over time. But how come like desensitization occurs in certain drugs and like not in other drugs? Like why doesn't it occur in this one? Yeah.
You are talking about the dopamine receptor agonists?
I suppose.
Or levodopa?
I'm not sure. To be I mean, I'm just whatever that contributes to the hypertensive crisis. So, yeah.
No. If you talk about receptor desensitization, you are talking about loss of the effect of a drug when it's given continuously or repeatedly. So you are talking about different issue.
Oh, so they are.
If you are talking about giving, I mean, chance to replenish the amount of epinephrine or epinephrine, whatever, you are increasing this amount, the amount of these catecholamines. If you think about it, like they are already there for a long time, and this will be desensitization. This could happen also. Okay, because desensitization is called also tachyphylaxis. If it's of the desensitization is for a long time or the loss of drug's effect is for a long time, they call it tolerance. Okay, if there is a loss of drug's effect, means this will be the opposite of what we are talking about. There wouldn't be hypertensive crisis. If I have these catecholamines, they're activating the receptor like beta 1 in the heart, alpha receptors in the blood vessels, and they keep knocking the doors of these. They said in the pharmacology books that the body is trying to avoid excessive activation of the receptors, so the body can down-regulate the receptor. This is one of the mechanisms, so that there will be no much receptors on the surface for the drug to work on. So the body is trying to avoid excessive activation. But again, this contradicts the hypertensive crisis, because if you are using this MAO-A inhibition, you are replenishing the amount of catecholamines. If they are there for a long time, long periods, the receptor may undergo desensitization or receptor down-regulation, and this will minimize their effect, not the opposite way. Is that clear? Or did I make it more complicated?
No, it's okay. I understood. Yeah.
Okay. Okay, let me stop here, because if I go more, it will expand more and more.
Yeah, I agree.
There is a question from Muhammad Yassin, says, Doctor, I have a question. Do the patient with Parkinsonism need to take the drug forever just to relieve the symptoms? Unfortunately, this is the way it is. Okay, you may just switch one drug for another, but the patient cannot do anything. There are some research using stem cells, but it's not to the clinical level yet to replenish the amount, because you know in the CNS there is no proliferation or regeneration of the cells, so of the neurons. So they are trying to use stem cells to create neuron cells, substantia nigra cells, so that this will mimic the normal person having sufficient amount of nigrostriatal neurons, and this will help it solve the issue. But this is not the up to the clinical level now. So what we have is just to trying to control the symptoms by these drugs, and even the symptoms themselves, they are controlled differently. If you remember from the videos that you have seen, that we said dopamine controls, levodopa controls the symptoms, the rigidity, the dyskinesia or akinesia more, and the anticholinergic decrease the affect this less, and so forth. I mean, so you have this, mashallah, big classes, big number of classes of drugs that can use to control the symptoms, to manage the systems and the symptoms. Unfortunately, this is what we have. So, Muhammad Yassin, did I answer your question? Okay. So, any other question? Okay, there is a question from one Amni Nadira. Levodopa will stimulate D2 receptors, right? But then D2 is GiPCR, which lead to low adenylate cyclase and low cyclic AMP. So that, does that mean in GiPCR low cyclic AMP means stimulation? It's more complicated than that, Nadira. Number one, remember that GiPCR, they decrease the amount of cyclic AMP. And remember also that the dopaminergic activity, when we are talking about the Parkinsonism or control of the movement, we have the excitatory one, which is the acetylcholine or cholinergic one, and we have the inhibitory one, which is the dopaminergic one. So here it goes okay with the low cyclic AMP means inhibition. Okay. So here inhibitory, it goes with the dopaminergic activity, which is inhibitory. But the mechanism how they initiate the movement is not known, because we said they trigger the movement, okay? But when you talk about, okay, the movement already started and now we need to control the movement by this such fine balance between the cholinergic and dopaminergic activity, the dopaminergic is inhibitory, right? Is that clear, Nadira? Okay, good. Any other question?
Doctor, I have a question.
Sure.
So do we stop the treatment only when the patients ask for it, or?
I don't think the patient will ask us to stop the medication because the patient needs, because affecting his or her life, right? So, but we cannot do anything to correct the main pathology. Okay, we cannot replenish the amount of nigrostriatal neurons. We cannot do something to replenish the amount of dopamine without using drugs. So, patient has to continue. If he or she stops, he or she will suffer.
When do we decide to stop the treatment?
When do we, I'm sorry?
When do we decide to stop the treatment?
If there is a, big amount of, big degeneration of the nigrostriatal neurons. We tried to use the dopamine receptor agonists, but the risks are more than the benefits. Then they use something called central dopaminergic stimulation, okay, CDS, which is kind of a little, I don't know, like device or something that put in the brain to stimulate the substantia nigra, so that will connect with the motor cortex and control the movement. So you can, at this time, you can switch to another little invasive procedure.
Understood, doctor. Thank you.
Welcome.
Doctor.
Okay.
So the first line agents would be the levodopa and carbidopa, right? Together.
Yes. Yes.
Why don't we use the dopamine receptor agonist as the first line agent?
Because, as I said, the efficiency of the levodopa will be more, specifically when it's used with carbidopa or benzoyl or any peripheral decarboxylase inhibitor. But there is a caveat here. If you use levodopa for a long time, okay, you may remember the issue of the wearing off phenomenon.
Yeah.
So you need to use something with it. Maybe use MAO-B inhibitor, catechol-O-methyl transferase, any other. You remember many of the other classes of the drugs are used with levodopa. You remember I said it's kind of there everywhere. So you might need to use other drugs to minimize the amount of the levodopa you are using, so the patient does not undergo this wearing off phenomenon. Okay. But it is the drug of choice, and always you start with levodopa with carbidopa or any other peripheral dopa decarboxylase inhibitor. Okay.
All right. Okay. So that means the dopamine receptor agonist you use in patient who already on the treatment of L-DOPA. So means like, I don't know, in the book it said that it's usually used in who is complicated by the motor fluctuations and dyskinesia due to the response to the
can you say again and speak slowly, please?
Sorry.
No, that's okay. Go ahead.
Right. So in the book it say how a dopamine receptor agonist is usually used in patient who is already on levodopa therapy. It's usually in patient who is complicated by the motor fluctuations and dyskinesia. So, so does this mean that dopamine receptor agonist is usually ineffective in patients who have not yet responded to levodopa?
I wouldn't say they are ineffective, okay, but I said the effect of dopamine, levodopa would be better. That's why we start with it. As you said, exactly, the book says that it's. Can you hear me well?
Yes, doctor, I can hear you.
Okay. So as you said now, from the book, it says used in complicated cases, along with levodopa to decrease the amount of levodopa. And also there is another issue. You remember the wearing off phenomenon? Wearing off phenomenon?
Yes.
Okay, do you understand that one? What is that? Okay, we said one of the issues with, yes, this is what you said now. The student was talking, I can't remember the name, was down here. Alisa, I think, was the one who's speaking now?
Yes, doctor, me.
Okay, okay, so there is this fluctuation. You said use these dopamine receptor agonists to prevent the fluctuation in response with long-term use of levodopa. Okay, so that's weaning off reactions and those akinesia. Okay, so they could be used in this case, okay, to prevent this fluctuation. Because what happens? You know what happened in this wearing off phenomenon? Can anyone explain? What do you expect?
The symptoms comes back.
Why they come back?
Is it because of the short half-life of the levodopa?
But this happens after long-term use.
Is this desensitization now?
It could be like that. It could be the degradation of the dopamine by the MAO-B and by the catechol-O-methyl transferase. So in these cases, so now the levodopa, you are giving the dose, okay, suppose it's twice a day. So now at the end of that 12 hours, maybe after 10 hours, the patient start getting back these side effects, or not side effects, the symptoms, clinical features of Parkinsonism, like rigidity, akinesia, and stuff. So this means that there is a wearing off. There is the amount of dopamine available is less. So in this case, you might use dopamine receptor agonists to keep the receptor stimulated, and the other thing is to use MAO-B or catechol-O-methyl transferase inhibitors. This also can solve this issue and like flatten the response. Instead of this, there is a response and then no response to the drug. The patient suffers from rigidity, akinesia, and then another dose that there is a response and then weaning off and so forth. Is that clear?
Yeah, all right. Understood. Thank you, doctor.
You're welcome. Okay. Other questions?
Doctor, I have a question.
Yes, Putri.
Regarding the dopamine receptors, which are the GiPCR, the D2, D3, and D4 receptor, what exactly they inhibit that is beneficial for Parkinsonism? Because agonist again for this is used as treatment. So I don't quite understand because they are GiPCR.
As I said, you need to control the symptoms of the Parkinsonism. You need to keep this balance again, right? So now you have the excitatory activity induced by the cholinergic system outweighs or wins the battle against the dopaminergic inhibitory activity, right? So you need to bring this balance again, okay, by bringing this activation of the GiPCR, which is inhibitory. So now there is inhibition. Without this inhibition, the stimulatory activity will be predominant, and there will be stimulation there will be rigidity, there will be all of this stooped posture and shuffled gait and all of these things. So you need the inhibitory activity of the dopaminergic neurons to inhibit the excitatory activity of the cholinergic neurons or muscarinic neurons. Is that clear?
Yes, doctor, thank you.
You're welcome. Okay. Other questions? Good. I feel like we are Alhamdulillah, things are getting better now. The more we discuss, the more I feel things are getting in the right way. If it's just the one-sided game, I don't think it will be good. There is a question came, I couldn't catch it. Can schizophrenia occur due to Parkinson treatment? Yes. As I said, it's kind of you are in the middle of these two roads. Okay, increased dopamine can cause schizophrenia. Decreased dopamine can cause Parkinsonism. Okay, so you have to calibrate, you have to monitor the dose you are giving. Otherwise, the patient may suffer from psychosis and schizophrenia. Okay, did I answer your question, Zulfakar? If yes, what we should treat first? What you do first is to, just as I said, to use the appropriate dose. Okay, don't exceed. If you exceed, you are going to go in the other direction that can cause schizophrenia, can also cause dyskinesia. Because what you need in Parkinson is, so what you need in Parkinson now, there is less of the dopaminergic activity, okay? There is less of the inhibitory activity induced by the dopaminergic neurons, right? You need to bring it back to the normal level so that there will be a balance between the excitatory cholinergic activity and the inhibitory dopaminergic activity. But if you use more of the dopamine, this can cause dyskinesia. Okay, this is another issue. But when it comes to schizophrenia, more dopamine again can cause schizophrenia. You have to monitor the dose so that you don't exceed and you don't give low dose. You have to use the appropriate dose. Okay. Oh, this is a long question. The function of catechol O methyl catechol transferase to degrade dopamine. Not only dopamine, degrades catecholamines, which include dopamine and epinephrine, norepinephrine. So we use tolcapone, entacapone to inhibit COMT from degrading dopamine, right? Yes. In the classification of drug slide, we use these drugs to inhibit L-DOPA from being degraded into 3-OMD. Is it like that? Because I search 3-OMD is an important metabolite of yes, they also prevent the degradation of levodopa also. Okay, so they prevent the degradation of levodopa, dopamine, norepinephrine, and epinephrine. That's right. So they will be helpful of replenishing the amount of levodopa and the amount of protecting the amount of dopamine in the substantia nigra. That's correct. Okay. This is Umaira. Umaira, is that okay? Okay. So catechol O methyl transferase, but we usually use entacapone more than tolcapone. As we said, tolcapone have some hepatotoxicity. Okay. So anyway. Okay. Okay. I think these are the questions I have. Okay, any other question? I'm opening the floor to any question you ask it directly using your microphone or message, whatever the question before, on the WhatsApp, whatever, so that we can enrich the session.
Assalamualaikum, Doctor.
Alaikum salam.
I have a
Jamila.
question. Does levodopa always have to be given in combination with peripheral decarboxylase inhibitor, or
Yes.
it always has to be? It can be given alone.
Yeah, because we said if it's given alone, about maybe 95% to 99% of it is going to be converted into dopamine in the periphery. So you are getting so much side effects and less of an effect, because it's the amount of levodopa that can pass through the blood-brain barrier is much less, very small amount, negligible amount. And at the same time, you are replenishing, increasing the amount of dopamine in the periphery, and you don't need this at all. So you have to use the peripheral decarboxylase inhibitors like carbidopa to prevent this from happening. Number one, to prevent the conversion of levodopa into dopamine in the periphery, so much of levodopa can pass through the big amount of levodopa can pass through the blood-brain barrier. Okay, this is number one. Number two, when you prevent the conversion of levodopa into dopamine, and then dopamine itself is a precursor for norepinephrine, then epinephrine, right? You are preventing levodopa from being converted into these unwanted catecholamines at all, because we don't need more catecholamines. We already have enough. If we need, the body will build or will synthesize these norepinephrine from the noradrenergic neurons, epinephrine mainly from the adrenal medulla, and so forth. Okay, so you need to keep using. When you use levodopa, there has to be a help from carbidopa or benzoyl, any peripheral decarboxylase inhibitor. There has to be. Otherwise, you are, instead of treating, number one, you are giving so much less or very less amount of levodopa that can pass through the blood-brain barrier, so you are not getting so much of a treatment. On the other hand, you are getting so much side effects. Is that okay, Camila?
Yes, thank you, doctor.
You notice now, just a side note now, when we show, so Camila asked a question that we really talked about it, okay, but when we elaborate on it, thank you, Camila, for your question. We talk about it, we elaborate more. The idea is much more clear. This interaction between me and you is long lasting in your brain. So when you need in the exam, you will have so much chance of remembering this. That's the benefit of this hot discussion. Okay, so the information is there, but when she asks about it, we elaborate more, we give examples, we discuss it, so it will be more long lasting. Thank you, Camila, and thank you for everybody. I like students who ask questions, specifically when these questions are quite related to the progress of the lecture. Okay, good.
Assalamualaikum, doctor.
Yes, Humaira. This Mariam.
If I may ask,
are you called them Mariam or Humaira? Which one of them?
Mariam is fine. Humaira is also fine.
Okay, Mariam.
Okay.
Okay, then I like Mariam. Okay.
Oh,
Right.
yes, please. Okay, I would like to ask about a question. You've mentioned that antiviral amantadine helps to potentiate in the synthesis of dopamine. Am I correct?
Yes.
Okay.
Actually, the exact mechanism is not well known. Just to make sure that this is clear, the exact mechanism of amantadine is not well known. Okay, but it might help with the more release of dopamine. It may enhance the synthesis, may prevent the reuptake. So and also the effect on MDA. Okay, so these are kind of proposed mechanisms of amantadine, but there is no clear-cut mechanism of amantadine.
I see. I would just like to ask for some clarification. Does this mean amantadine can only be prescribed if the substantia nigra is preserved, as in the early cases of Japanese encephalitis? So does that mean we only have to prescribe the patient with amantadine instead of the other medications?
Yes, that's correct. Because it's already is antiviral. Okay, it's antiviral. So if the patient have Japanese encephalitis and generally speaking, to flatten the response of the dopamine you can use it along with it, but it's not used that much, the amantadine. Okay, and all of these proposed mechanisms, as I said, it's just proposed ones. There's no the exact mechanism is not quite clear. But if there is a big damage and the nigrostriatum, I think you don't use this. You can use the dopamine receptor agonist right away that can stimulate the receptor, or use the central dopaminergic stimulation device to stimulate the basal ganglia. Okay, Mariam?
All right. Thank you, doctor. Thank you so much for the
You're
clarification.
welcome. You're welcome. Thank you for the question. Okay, other question?
Doctor,
Yes, Putri.
can I ask? So basically, to summarize it all, not summarize it all. I mean, like essentially, we just need to, the drugs are to balance the dopaminergic, the dopamine and the acetylcholine. And if it's too much, it will cause schizophrenia. So we need to prescribe to the patient to balance, just to balance the dopamine and the acetylcholine equally. Is it?
Yes, that's quite correct. 100%. Yes, you need to keep this balance, bring this balance again, but you don't overdo it. Okay, you don't use so much of the whatever the treatment for the symptomatic treatment of Parkinsonism, because otherwise you are increasing the amount of dopamine. You may go to the schizophrenia and also the other dyskinesia and side effects of the drugs for symptomatic treatment of Parkinsonism. Yes,
Okay, thank you, doctor.
you're welcome. Okay, other questions?
I think that's all, doctor.
So no more questions?
Inshallah, none at the moment.
Okay, if you still have questions, you can again post them on the WhatsApp group, in my private WhatsApp, or under the video. I will do my best to answer them, inshallah. Okay. Again, last call. Okay, any other question? Okay, if none, let us finish this session with تسبيح كفارة عن سورة العصر. بسم الله سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. بسم الله الرحمن الرحيم. والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. Okay, guys, see you tomorrow, inshallah. Assalamu alaikum.
Walaikum salam.
Waalaikumsalam. Thank you, doctor.
Thank you so much, doctor.
Thank you. Thank you.